Top Bed Talk.
Professor Duminda Wijeysundera is a professor of anesthesiology at Toronto, and I'm sure if you read the famous paper came in the Lancet on preoperative stratification, you will hear today something. Okay, thank you very much. Thank you very much. Okay.
All right. Thank you very much, Franco, for the very kind introduction, and really thank you to the organizers of the World Congress as well as EBPOM London for the opportunity to speak here. So I think this session is focused on controversies in various areas. I'm going to talk about preoperative risk stratification and the role of exercise tests in preoperative risk stratification, looking at both areas of uncertainty as well as updates in recent evidence. So in terms of disclosures, I have no conflicts of interest, but I always want to point out the various sources of funding that both support my time outside the operating room as well as my research program. So this is what I hope to cover in the next 15 minutes or so. I'm going to focus principally on exercise tests and really the gold standard non-invasive exercise test that many of you here in the UK are familiar with, so cardiopulmonary exercise testing. But I'll also talk a bit about, I think, a relatively simple alternative that certainly some have suggested is a potential proxy measure of exercise capacity in surgical patients, the 6-minute walk test. So we're going to talk about the conduct of those tests, the evidence supporting risk estimation using both tests, and then I'll finish off with some practical guidance for, I think, informing clinical care. So to begin with, let's look at the conduct of cardiopulmonary exercise testing as well as the 6-minute walk test. So this is a relatively easier talk to give here in the UK. I think many of you are quite familiar with what a cardiopulmonary exercise test is. When I give a talk like this to a North American audience, they'll look at this guy and say, why is he wearing a mask while doing a stress test? But as many of you know, it's a variant of an exercise stress test where, in addition to standard physiological monitoring, you get measurement of oxygen uptake and carbon dioxide production, and you get this very integrated sense of the cardiopulmonary response to incremental exercise. There's a lot of physiological data that comes from a cardiopulmonary exercise test. This is not a test where there's a single metric that defines performance, but the typical metrics that have been used in the perioperative literature include peak oxygen uptake, or VO2 peak, anaerobic threshold, to a certain extent ventilatory efficiency, VE over VCO2, as well as a failure to complete a test. And so this is really the gold standard non-invasive test. Why would you want to choose something or at least explore something aside from this? And this is often a challenge in settings, certainly outside the UK. So I practice in Toronto. And for us, we do have a CPET clinic, but certainly if we sent even a small fraction of our surgical patients, it would basically overwhelm the resources that we have to conduct cardiopulmonary exercise testing. Because while it is a gold standard test, it does require resources, it does require expertise, and none of these are free. And this has been often a challenge in implementing CPET services on a wide scale at many centers. So at many centers, including my own, there's been an interest in alternative, simpler tests. And often these tests fall in the body of what are called field walking tests or functional walk tests. The most commonly used one is a 6-minute walk test. There's an alternative called the incremental shuttle walk test. I won't talk about this in the presentation. We can talk about it afterwards if you want. But the 6-minute walk test is exactly what its name says it is. So you get a patient and you make them walk for 6 minutes. But there's some more details. So there's a prescribed track that has to be 30 meters with marks 3 meters apart. There are cones at the end, and they're very strict prescribed instructions that patients are given before the test, and they're instructed to then walk for 6 minutes without encouragement. In addition to the distance walked, you get measurement of pulse oximetry as well as the dyspnea using a standardized scale. And importantly, as I mentioned, there are standardized protocols that have been defined. These are the most recent versions at the top from the European Society as well as the American Thoracic Society, an older one from the American Society back in 2002. Essentially, if you conduct this test, you do need to follow these prescribed guidelines so you make sure that your results are comparable to standards that might have been performed at a different center. So why is it used, or why has it been interested in this? Well, frankly, it's a simpler test. You require a hallway, some cones, and a stopwatch and some way to measure oxygen saturation. But in addition, there's evidence, certainly quite wide evidence in the non-operative setting, that it is a valid proxy measure of exercise capacity in that CPET performance has been correlated with walk distance on a 6-minute walk test. Now, there are limited data in the operative setting. These are probably the two most relevant studies. The picture on the left is a scatter plot showing the relationship between 6-minute walk test distance and anaerobic thresholds in a single center study here performed in the UK of about 110 patients. The figure on the right is data from the MET study. This was a study focused on cardiopulmonary exercise testing as a preoperative risk stratification tool. But in about 545 patients, we also got them to do a 6-minute walk test. And that shows a correlation between 6-minute walk test distance on the x-axis and VO2 peak on the y-axis. And essentially, the correlation in the reported literature is fair to moderate. So the correlation coefficients are about 0.4 to 0.7. It's not fantastic, but it's acceptable. And this range probably falls in what you've seen in the non-operative setting. So it has validity as a measure of fitness, but there are some limitations with this test. And what are some of those limitations? Well, it's a test that involves walking and making turns. And anytime you make an older patient do that, there are going to be issues where their performance is limited by other factors, such as coordination or simply the fact that they have arthritis. There's also an important learning effect with this test. So what I mean by that is if you do a test today, and then you bring the patient back and you make them repeat the 6-minute walk test, their performance may increase up to 15% simply because they figured out how to do the test better. And that is independent of performance. And certainly in the non-operative setting, you often do these tests twice to get a better sense of what their baseline level is. But in the operative setting, we often get people to do a single test because that's what's practical. So theoretically, at least, it raises issues with the signal-to-noise ratio with this particular test. So what do we know about prediction of postoperative complications, let's say with the gold standard test? And I'm going to focus on CPET. So there's a vast amount of data already published on CPET and its relationship to postoperative outcomes. Multiple single-center studies, several systematic reviews. This is one example published in 2016, which identified almost 40 studies, more than almost 8,000 patients. And if you look at the literature in totality, it essentially shows that poor performance on CPET based on low VO2 peak, a low anaerobic threshold, or the failure to complete the test identifies people at risk for dying or having complications after surgery. It's a fairly consistent message. So what are some of the limitations with those data? Well, the majority of these data sort of came from studies where they analyzed pre-existing clinical registries of patients who underwent preoperative CPET. So in general, these studies were unblinded. So the decision to proceed with surgery, the type of care you received before, during, or after surgery may have been modified by CPET, knowing the CPET results. So theoretically, there's a bias introduced from that. Certainly from a non-UK perspective, since I practice in North America, most of the data comes from the United Kingdom. I'm not saying that's a problem, but it made it more difficult for us to convince certainly our funders to believe that the same results would be extrapolatable to CPET centers at centers, let's say, in Toronto. And interestingly, if you look at the types of events that occurred in patients with poor CPET performance, in general, interestingly, most of those events were non-cardiovascular complications. I'm not saying that's a limitation, but that's an important issue, that most of these events tend to be respiratory type events as well as infectious events, but not myocardial infarction or myocardial injury type episodes. So I'm going to focus a little bit on the MET study. This is what Dr. Carley mentioned. So this was a study that I had the privilege of co-leading with Brian Cuthbertson from the University of Toronto, but it had a huge amount of UK representation and involvement. It was led by Rupert Pearce, Mike Grocott, and Tom Abbott here in the UK, among others. And a lot of representation from Australia and New Zealand, where it was led by Paul Miles at the Alfred in Melbourne. So this was a study that targeted to aim to recruit about 1,400 patients who were undergoing major inpatient elective non-cardiac surgery. And the principal objective was to compare 4 different measures of preoperative functional capacity. So this physician judgment, CPET, a DASI questionnaire, which is a standardized questionnaire, as well as a blood test. I'm going to focus really in terms of the CPET results for the purpose of this presentation. So cycle CPET here was performed, and the principal metric of fitness that we used in the study was peak oxygen consumption. So a couple of things. We looked at the relationship of CPET performance with a range of outcomes, which included myocardial infarction, both 30 days after surgery, as well as myocardial injury 30 days after surgery. But one of the other important outcomes we measured was major complications. So these are moderate, severe, or fatal complications. And an interesting observation from the MET study was that in general, if you looked at people who had major complications that occurred, well, a certain proportion of them had cardiovascular events. So about 5% of them had myocardial infarctions. So what you see on the left column are individuals who had no complications or mild complications. On the right is moderate, severe, or fatal complications. So 5% of patients who have moderate or worse complications had a myocardial infarction. But what were much more common in these individuals were actually respiratory events, such as respiratory failure or pneumonia, or infectious events, such as surgical site infections, or perhaps ICU admissions that were unexpected. The dominant events were non-cardiovascular. And that's an important observation that I'll come back to. So how did CPET actually predict major complications? So we actually found that when you adjusted for demographic factors as well as surgical risk factors, a lower VO2 peak was highly associated with an increased risk of postoperative complications, and that risk was essentially linear. The lower your VO2 peak went, the higher your risk of complications. But often operationally, when we think about clinical practice, we tend to categorize patients. We kind of identify what's a threshold in VO2 peak that kind of matters. And these are some more, sort of unpublished data from the MET study for some secondary analyses that we're conducting, and where we categorize patients into quartiles based on their VO2 peaks in the particular study. So if you look at the best quartile of a VO2 peak greater than 22, you essentially see that as you go down lower in terms of quartiles of worsening VO2 peak, you see an increased adjusted odds of complications that increases in a stepwise fashion, such that when you reach the lowest quartile, so a VO2 peak of less than 15, or the inability to complete a test, your risk of postoperative complications was more than doubled, and that was highly statistically significant. Importantly, the association of CPET performance with outcomes was really restricted to postoperative complications, which, as I mentioned, were predominantly non-cardiovascular. It did not predict, to our surprise, myocardial injury or infarction. So this was largely prediction on non-cardiovascular complications. So if you look at how this integrates with previous evidence, we already know that the previous evidence showed that CPET was a strong predictor of postoperative complications, and the MET study was actually largely consistent with that. It found that it predicted complications that were largely non-cardiac, and in this particular study, we found that VO2 peak was the best predictor among the metrics that we tested. And if you found a category that was highly indicative of increased risk, it was a VO2 peak less than 15, or the inability to complete the test. So there is the most complex test. Well, how does a simpler test actually perform? The body of evidence for the prediction of complications by 6-minute walk test is far more limited. And these are 3 particular studies that have assessed this issue. They're all about 100 patients in size. And the results are mixed. So the top study is a study from Thailand, which found that a 6-minute walk test distance less than 325 meters predicted an increased risk of pulmonary complications. A study from Brazil, which found no association. And a study from Montreal from Professor Carley's group that found that there was an association between 6-minute walk test distance and medical complications after surgery, but the magnitude of that association was relatively small. So, as I mentioned, we did perform a 6-minute walk test sub-study in the MET study. It was 545 participants, and the primary outcome for that study was actually disability-free survival at 1 year after surgery. But for the purpose of the presentation, I'm going to focus on complications, so we have some basis for comparison against what we know about CPET. So does the 6-minute walk test actually predict postoperative complications? And these are some unpublished data. There's certainly a suggestion that there may be some relationship, but it is relatively weak. So what you see here on the x-axis is 6-minute walk test distance, and what you see on the y-axis is the risk of complications expressed in the Logit scale, which is what you do with this type of modeling. So there appears to be a linear relationship. The p-value is 0.04, but frankly, this is a possible association, but based on the statistical strength of evidence, is not hugely compelling evidence. It suggests that this is something that we need to explore more. What if you categorize things, much as what we did for the CPET results? Well, if you consider categories and you categorize them again into quartiles and you compare them against the highest reference category, which was 534 meters, if you look at the lowest quartile, which is less than 411 meters, then there is a suggestion that there's an increased risk of complications. But again, the p-value is 0.07, so it's suggestive, but by no means definitive. What are some of the reasons for that? Perhaps it's that, frankly, this is not such a great test for predicting postoperative complications. The other aspect is this was a relatively smaller study with about 500 participants. Perhaps with more participants and more events, we can get a better sense of what the actual relationship is. So what can you say about the 6-minute walk test? Well, I think it's a little less certain. It's an inconsistent predictor of complications. Most prior studies did not find a prognostic role in non-thoracic surgery. In thoracic surgery, the data are quite different, but we're really focusing on non-thoracic surgery or certain procedures aside from lung resection. The MET study did suggest that there was some increased risk with a walk test distance less than 411 meters, but I think that's something that requires further exploration in the future. And why might that be the case? Why did that test not perform as well as we would hope it did? Well, aside from the limited sample size, there may be, again, the problems inherent to the test, that of a learning effect, and the fact that test performance is affected by a bunch of factors actually aside from fitness. So how can you integrate all of these things and actually apply them to your clinical practice? Well, I think one important message from the MET study is that we often think about the relationship of exercise capacity to cardiovascular outcomes, but I would suggest that really, when we think about tests that objectively measure cardiopulmonary fitness, we really have to think a little bit more about its relationship to important non-cardiovascular complications. And we can talk about that further in the question and answer session. But really, I think the types of events that occur more often in these patients tend to be pulmonary events and infectious events. If you're looking for myocardial injury or infarction in patients with poor fitness, I think that's probably not the most efficient way of using this particular type of risk stratification approach. The CPET test, I think consistent with the previous literature and the MET study, is a specialized test, but it has consistent evidence as a predictor of complication risk. The CPET, the 6-minute walk test, is a simple and valid measure of exercise capacity, but is it a substitute for CPET? Is it a reasonable screening test? I think we simply don't know that right now. And that's an area where we need further research to define whether it fits that role and perhaps maybe a substitute in some centers. Alternatively, it may not be an appropriate exercise test for this purpose. But that's one of the things where we need to move forward in terms of research in this area so we can better apply exercise testing in a rational manner to our patients so we can improve their care and hopefully their outcomes as well. Thank you very much.
Wijeysundera here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.